and I just want to welcome you to Treatment Planning for Comprehensive Tooth-borne Cases. And this lecture is being brought by Tremaine Watkins, CDT, and I am so pleased to introduce Tremaine Watkins. Tremaine Watkins has been working in the dental laboratory industry for more than 30 years. After graduating with a Bachelor of Arts from Trinity College in Issaquah, as class valedictorian, he has gained extensive experience in all aspects of fixed and removable restorations, with an emphasis on implant-supported and retained restorations. He has also provided clinical support for case planning, troubleshooting, and implant placement. He has trained other technicians in all aspects of dental technology and has written and lectured on several aspects of restorative dentistry. It's my pleasure to introduce Tremaine again, and the floor is all yours, Tremaine.
So thank you, everybody, for joining. I would echo what Nicole says, that we know that you have a lot of different options in front of you, and we really appreciate you joining. So tonight what we're going to talk about is how to do large tooth-borne cases. Now, as you guys know, many of these cases may have an implant or two involved in them, but what I'm trying to differentiate is between these kind of cases and then all on X, where you're doing mostly where you're doing a fully implant supported case. Now, a lot of this is applicable, but I feel like this is an area that the enthusiasm for all on X is so high. I feel like sometimes this area gets a little bit neglected. So I think that it's good to to brush up on this. So anyhow, again, thank you very much for joining us, and here we go. Okay, so I am an employee of National Dentex Corporation, was paid to make this presentation, but other than that, I am, there's no commercial subsidies of any kind, so any opinions that I have here are based on what I've had good success with or other people I know and trust, and there's no financial aspect to it. And then again, there's no commercial support. So let's talk about finding the best outcome for your patients. One of the things that's interesting about, at least for me as a technician, is as cases get larger, there are more options for what I can do with it, and even more good options in a lot of ways. So for instance, if I'm doing a single central, most of the time the shade's going to be a little bit challenging, but the contour is pretty straightforward because ultimately a perfect result would mirror the contralateral tooth. On the other hand, let's say I was doing a 6-unit bridge, 6 to 11 with 4 ponics. I would have a lot of flexibility in where I put those teeth. So therefore, I need to kind of have a good plan to figure out where should those teeth go. And that's what we're going to be talking about this evening, is like, how do I know where to put my teeth to get a good result? And kind of how to narrow down. So I find my 40 options and I narrow it down to just a few, to one that I believe will give a good result. So one of the things, and we'll talk about this a little more detailed later, but you need to have a team to be consistently successful with these kind of cases. Of course, that's modern dentistry. We all know that. But it's good to be deliberate about this process. And one of the things that I would recommend is use each case that you send to a dental specialist or to a dental laboratory as an evaluation process. What can I get from this person? What are they good at? What kind of results do I get? We'll talk about this with materials later, but I feel like with referrals, this is also very important, that you have a team that you know is solid before you start doing these cases. The other thing I would say, and you'll see that this is kind of an assumption in this presentation, is that the general dentist is the quarterback for these cases. While there will be a lot of other people playing roles, because this is fundamentally about restorative dentistry, then as a general dentist, you'll kind of lead the team and then bring, to continue the sports analogy, bring other players on as needed for particular situations. So let's start off with patient communication. And you all talk with patients every day, and you might think, well, obviously. But think back about your own experience. When I think about the cases that I've been involved in that really went south and that I think about 20 years later, they oftentimes boil down to poor communication. Either the clinician didn't understand what the patient wanted, or we didn't understand in the laboratory what the clinician wanted, or we didn't communicate, especially long ago, what our limitations were. And I would say that's one of the coolest things about doing dentistry today. When I was younger, there were cases that literally couldn't be done. Because when I got started, dental implants were brand new, basically. And so they weren't widely available. And it wasn't just kind of like, oh, I'm missing a tooth, let's drop an implant in there. It was like, well, are you a 32-year-old triathlete? Well, you may not be a candidate. Anyhow. So there are cases where we'd work really hard and the result just wouldn't be that good. Today, we can pretty much do whatever we want to do as long as the patient can afford it and is willing to go through the time that's involved in it. We need to really listen to our patients. Everyone on this call is an expert in dentistry. And so it's very easy to look at a person and say, well, I know what this person needs. But sometimes we can get kind of lost in our own expertise, so to speak, and not listen to what does the patient not like. Sometimes understanding that is going to totally change the direction that we go in with our treatment. And sometimes we're going to, as we're kind of working through our treatment planning and then actually our execution of our treatment plan, we'll be like, okay, I have to go in this direction because this is my patient's primary concern. If gingival symmetry is a key, then we're going to need to do whatever we need to do periodontally to make sure it works. The patient's like, I see it, but I don't really care. We may not need to do that surgical step. So that's really important. And then I feel like it's important for us to repeat back to the patient, use that active listening to make sure that they know that we understand what they want. If we see just from an overview perspective that there are going to be difficulties in delivering that, it's good to talk about that right up front. If we have a conversation ahead of time about the difficulties of matching a shade for a single central, or how we need to open the bite, but it might feel a little bit different for a while, or whatever those conversations are, when those things happen, the patient's like, oh, doctor told me. Okay, well, that's what I was told, and now it's happening. On the other hand, it can easily degenerate into blame if we're trying to explain things after the fact. So and I don't know if I really go into this at each step, but at each step in this process, we want to make sure that we're communicating with our patients like, we're doing this step because you want this, and this will give you this result. These are some of the positive aspects of it. These are some of the negative aspects of it. And I think that last but not least, all of you are involved in CE, and a big part of this is making sure that when your patients come, even with unusual requirements, the more that we know, the more tools we have in our dental toolbox, the more able we are to serve them effectively. So, staging of treatment. Sometimes you can just plan these cases, prep them all, deliver the crowns, and everything's good. But sometimes you're going to need either surgical or orthodontic therapies that are going to require some healing, or patients want to break up the cost, or you're thinking to yourself, prepping 26 teeth at the same time may not be the funnest thing in the world. So you need to be thinking about, we'll kind of revisit this as we're going along, like, does this case need stage treatment, and how am I going to handle it? One of the things that can be really important is how good things have to look at mid-process. And I'll give you an example. Let's say that we're doing a full upper arch and the patient wants to do the anterior teeth first and then the posterior teeth later, and they're overclosed. So what we might do is we might do occlusal bondings to open their bite up, and then most people want their teeth lighter than they were before when they're done. So there may well be an interim process where you've delivered the anterior teeth and they look great. The incisal angles are great, the midline's great, the contours are great, symmetry, shade, everything's great, but the posterior teeth are much darker and have a strip on the top of them where that onlay is sitting. Okay, that's fine, but that's definitely part of the conversation. So we want to make sure if we're doing that particular treatment, we've told the patient, hey, we're going to get everything planned. We're going to work together to make sure that we have a plan to give you the smile that you want. And then because you like to do it in 2 parts, there's going to be a stage for a few, let's say 2 or 3 weeks, where your front teeth and your back teeth look quite different. Are you okay with that? And then whatever the answer is, we deal with it. So if they say, well, no, I want my teeth to look perfect all the time, you're like, great, let's talk about how we're going to prepare all your teeth at the same time, how we're going to extend to the first premolars, whatever, make a plan. The other thing is, for cases that require surgical intervention or implant placement or whatever, we need to think about how can we help our patient look as good as they need to be. And on the flip side, how can we underpromise and overdeliver? We want to make sure that in those interim stages, what the patient is experiencing is what we described or better. We don't want them to ever be at a stage where they're like, well, you didn't tell me it would be like this. So be thinking about that. We'll be talking about different stages of treatment, but I kind of roll this in with the patient communication phase because it's really important for us to make sure that our patients know not just where we're starting and where we're ending, but whatever steps are going to need to be involved along the way. Oh, one other thing I would say about that is that there are oftentimes multiple options. Let's say you're placing a single implant and it's an immediate and you'd like to do a custom provisional so that you can shape the tissues and all that stuff. And so you talk to the patient about it and you tell them how awesome it is and you tell them how much it's going to cost. They're like, oh, I don't want to pay that. You say, okay, well, and then maybe your least expensive option is a healing abutment and a flipper. You say, oh, well, I can do this for you for this. But you'll have this big thing in your mouth that's flopping all around. And they say whatever they're going to say. I like it, I don't like it, whatever. As long as you've accurately communicated what you would like to do and what the benefits and drawbacks are of each, it's a win. If they do what you want, the best case scenario, then you've given them the best case scenario. Great. If they've chosen a less awesome scenario, still they own it. And so when it's less awesome, they can look in the mirror and say, oh, you know what? I think I should have listened to doctor and picked the better option. Well, lesson learned. So either way, you're kind of building your credibility, building your relationship with the patient, and helping to manage their expectations and then exceed their expectations throughout the process. So we'll start out by getting some imaging of the patient. If you have 3D facial scanning, that's awesome. As a technician, I think that's the best thing ever because while I get the benefit of seeing patients chairside, a lot of my colleagues don't. And so being able to see all those tissues that affect our result, the lips, the nose, the chin, the eyes, in 3 dimensions, and you can rotate it and look at how your how your proposed teeth are going to affect the upper lip. Oh, it's the best thing ever. So if you haven't ever tried 3D facial scanning, you might give it a shot, because I think you'll find it's pretty cool. And especially for your laboratory, it allows your laboratory to see in their design software what you can easily see clinically. So if you kind of get cases and you're like, well, how could they have done that? That's the dumbest thing. But it's like, well, how's it look on the model? Oh, it looks pretty good on the model. Well, there you go. They're just, sometimes there is other very important facial information that doesn't get picked up by a model. If you're not doing 3D facial scanning, which I think is most people today, photos are really, really important. So the top two photos in this are probably the most important for this. One is the low lip, where the patient's lips are parted and relaxed. And what we're looking at there is the incisal edge position of 8 and 9, because basically our whole aesthetic tooth arrangement comes from there. And we'll talk about that more as we go along. And then the high smile is important because we need to see the gingival margins and look at any asymmetry, see how important it is. In other words, like this particular patient doesn't show very much gingiva and everything looks pretty good. But another person might have a gummy smile, and we need to know that early. Because again, those kind of surgical interventions need to be done earlier in the process. Take those pictures both frontally and in profile so your laboratory can see that. And, it doesn't hurt. Obviously, these, like the middle photo and the bottom, those become most important for single teeth, or if there's textures that you'd like to your laboratory to replicate. So photos, facial scans first, photos second. Either way, if you have to take a shade, and I guess we can talk about this in a minute, but make sure that you take the shade. There's no machine out there that can take a beautiful, perfect shade on a single central, in my opinion. Speaking of, I wanted to work a picture like this into a show forever. So that's the point of this picture. Some of these cases doesn't really matter what shade it is. You hold up the shade tab, the patient points at one, and that's it. But there are going to be some that we're doing that we do need to match surrounding teeth. And so there's a few things. I did a little class on this, so this is kind of the truncated version of it. But we want to keep in mind that color isn't a property of a material like mass. In other words, color is affected by three things: the quality of the light that hits the object itself, and the receptor. So the first thing is we want to make sure we have enough good quality light. Light bulbs are rated by CRI, or color rendering index. The higher the number, the greater percentage of the spectrum of visible light they emit. We should use 95 or better for shade taking, 95 or higher. Keep in mind that 1 in 12 men are colorblind, while only 1 in 200 women are affected. So we want to make sure that, depending on our gender, we test ourselves and make sure that we can actually see color. That's really important. We want to make sure we put ourselves in a nice neutral shade environment, including, like, we don't want to have too much bright colored lipstick. We don't want oddly colored bibs, oddly colored rooms. And then we want to get the right amount of light so we can see, but it's not so powerful that it overpowers our eyes. And here's the most important thing. Take the shade as soon as the patient sits down. Don't wait until after treatment, because teeth get lighter during treatment as they're desiccated. And it varies from person to person, but you might find that your shades tend to run about a half shade light. And the reason is because of dehydration. So one of the things you could do in your practice is pick your best shade taking assistant, ask him or her to be the patient seater, and then have them just bring the patient in, sit them down, take the shade, take your photos, and then that's A, it's already handled. You don't have to worry about it. And B, you're getting that nice, you're getting a shade the way that, matching the teeth the way they are most of the time, as opposed to how they look when the person's mouth's been open for an hour. So it's really important. I would say if you want to do one thing tomorrow to make your shades better, take the shades before treatment. Photos for shades specifically, very important. If you've ever been to a laboratory or ever watched the way that laboratories do custom shades, essentially it's finding close shade tabs and taking a really good photo. So if you can do that, you can get good custom shade quality results from your laboratory. So the first thing is you want to pick a shade tab that matches the middle of the tooth within half a shade. It doesn't have to be perfect, but it shouldn't be off by a country mile. I'll talk about how we use these photos in a minute. Especially if you're using your phone, make sure that the labial surfaces of the tooth and the shade tab are exactly parallel to each other. Very important. Cameras seem to be very sensitive to shadowing. So if the shade tab is a little behind, it tends to look low in value. And if it's a little labial, it tends to look high in value. Make sure you capture, which we didn't on this one, make sure you capture the name of the shade tab, or when you're naming the photos, say, I don't know, this is probably a BL3-ish. So call it BL3 tab or something like that. So that way your lab knows, oh, that's a BL3. And then make several photos of each tab. Take them from different angles. And what you're looking for is you hold up your camera, your phone, let's say, and you look at the patient and you want to make sure that the two look the same. Once you start doing this, you'll be amazed by how many times you look at the photo and you're like, holy smokes, this doesn't look anything like reality. So if you take, say, 15 to 18 photos, you'll probably be able to winnow it down to 3 or 4 that look really good, that are really sharp, really and very true to color. The other thing to keep in mind is when you send your photos to your laboratory, make sure that you send them full-sized. A lot of phones, you need to stay back a little bit from the patient to get good focus, and that's fine. Good focus is critical because we can use digital zoom as long as you send it with lots and lots of megapascals. Or megapixels, sorry. Megapixels. So if you can get good photos, you can get a good custom shade quality result right there in your office. So that's really important. Of course, you're going to do radiographs. You'll do PAs or probably panos for diagnostic purposes. If you're planning on placing any implants, I would strongly recommend having a CBCT scan done. Reason being that it gives you the option of using guidance if you want, and it also just gives you so much more information about bone volume and the like. You'll get a better result with a CBCT scan. But it's not just about that. It's also about kind of looking at what's going to happen as you move along in your therapy. So I like this picture because you guys know, you extract these teeth, the tissue is going to collapse. This person's going to have a U-shaped defect here before too long. So this is a great time to have that patient conversation. You can say, hey, you know what? You have a lot of periodontal disease in this area, and I need to take these teeth out. And I can address this in several different ways. The prettiest way would be for me to do some bone grafting and tissue grafting to replace all that bone that's been lost and place a couple implants for you. And I can get a very nice result as almost the same as nature as you were before. You tell them the price. They say, oh, I don't want to do that. It's too expensive. You say, okay, well, I can also do a 4-unit bridge for you, let's just say here. But because of that large space, the U-shaped defect, we're going to have to add some pink porcelain. And so you'll probably see a little gap around the edge of the pink porcelain. And porcelain and tissue are two different materials, and so it'll look a little bit different. If you like that, that's okay, and I can get that's I'd say that's my better solution. And I say, well, I don't want to do that either. You say, okay, well, I can do a partial for you. It'll definitely have a seam. So, I mean, you guys know this, you do it all the time, but I think that it's not just about figuring out what you need to do. It's also thinking about how this affects both mid-process treatment. In other words, is this going to create an odd stage, or do you need to discuss multiple options? So, and again, I was looking at my own notes here. It reminded me, the implant also will have the best hygiene. So if the person chooses the bridge with the pink, it's going to be more difficult to floss. And so they need to be aware of that ahead of time as well. And again, hopefully they choose the best option. That's why you're there, to help them. But even if they don't, when they experience the less awesome results of their own decision, then they're like, oh, okay, well, doc told me about this. I should have listened. Anytime they say I should have listened to the doctor, I'd say that's the second best alternative. The second best to they do what you tell them to do. All right. So obviously one of the main reasons that we do our radiographic analysis is to decide, do we need to save any teeth with endodontic treatment? Do we have teeth that have endodontic treatment that that may need to be retreated or may require us to go in a different direction with our restorations? And I put this in because obviously both are great, and we all know that having your own teeth is really good. But we also want to talk to our patients. Most of the time, these cases are going to be a pretty substantial investment, and we want to talk about return on investment. And as an example, the average lifespan of a 3-unit bridge is between 8.3 and 10.3 years. So on average, every 3-unit bridge will have failed in 10 years. On the other hand, a single tooth implant has a 95% success rate at the same time. So if they choose a single implant, most likely they'll still have that tooth in 10 years. And if they choose a 3-unit bridge, most likely they won't. And again, it's okay either way, but it's good for them to think about not just immediate cost, but long-term value. And I think that's the reason I put it on the endodontic slide, is because you kind of want to look at the case and say, does this tooth have a pretty good prognosis? And do I feel comfortable with this? Or am I kind of doing a Hail Mary, and do I need to talk to them about, this may buy you 2 or 3 years, but you're going to be back here doing something else. You want to make sure both that you're providing yourself with a strong foundation for these comprehensive cases, and that you're using your crystal ball the best you can to give your patients an idea of how their current decision making is going to affect their long-term dental health. Gingival position. A lot of these cases, we're going to be looking at how much gingiva shows when the person smiles. Obviously, lip mobility is a huge variable here, and this is something that's changed quite a bit over my lifetime, which is interesting. It seems like people want to see less and less gums. So this is definitely a place that starts with your conversation with the patient. How do they perceive the amount of gingiva that they show when they smile? Maybe they show a ton and they don't care. Maybe they show a little tiny bit and wish it was gone. Whatever the case is, this can be, because this is mostly an aesthetic decision, by and large. I mean, every once in a while we need some extra crown length for ferrule, but most of the time it's related to cosmetics. So we want to make sure that our patients understand, tell us what they want, so that way we can get this part of the treatment figured out well. One other thing to keep in mind is that it can really help your surgeon to provide a stent. So once you've done a mock-up of whatever you want to achieve, as this person did here, you'll make a little vacuum form or something like that over it, and then your surgeon can reflect the tissue and push the bone up a couple millimeters past here, suture everything up to get a very predictable result, so that way when everything's healed up, you have those margins exactly where you want them to get a nice result. So work with your surgeon on this, and again, try it on a single premolar that you don't really need it for before you start doing 6-unit crown lengthening cases, to make sure you guys are communicating well and the components that you're providing are actually being helpful. Ponic planning, this can be a good time to look at ponic planning. I think most people would agree that if you have to do a ponic, the most hygienic and aesthetic result is an ovate ponic that's kind of egg-shaped and sinks into the ridge. Now, if you're doing an extraction and delivering a temporary bridge right away, that can be an awesome time to shape this. You can have your laboratory make you a nice prefabricated PMMA shell with a perfect shape, extract the tooth, rough prep these teeth, and deliver that provisional so that the gingiva can heal right around it, just like you would for an immediate implant provisional. If the person's tissue is healed and you're doing crown lengthening, you could consider doing shaping up an ovate ponic at that time. If you're not needing to do any other surgery, you may decide that doing an ovate ponic probably isn't worth the headache. But be thinking about this because a lot of times there will be an extraction involved, and it's nice to be able to, shape that tissue right at that point. You don't have to get very far in full arch dentistry to realize that occlusion is arguably the most critical part of treatment planning and delivering these kind of cases. A lot of times when we're doing single tooth dentistry, we take a nice bite registration and we build our new restoration so that it doesn't mess up the patient's function. But when we're doing these kind of cases, oftentimes we have the ability to change the vertical dimension of occlusion, to change the jaw relationship in terms of our CR, and change our tooth position as well. As you know, the TMJ is the only rotating and translating joint in our whole body, and which making it the most complex. And while the arguments about occlusion aren't as vociferous as they were when I was younger, there's still, I would say, are more than one opinion on this. You are going to find some situations where your patient's asymptomatic and you look at their face and you don't see a need to make any changes. But a lot of patients who are coming to us for comprehensive treatment are in need of replacement of lost vertical, and or they may have developed a centric occlusion that is functional because of their current tooth arrangement, but not really ideal. So we'll want to make sure that we evaluate their vertical dimension of occlusion and we restore to the full VDO. And for many patients, if we can make CR and CO coincident, they'll be more healthy. So I'm sure a lot of you have seen the Conmedior instrument, and I think it's super awesome. A lot of people like it. I thought today, since I'm being a little bit contrarian, talking about Tooth-borne stuff anyhow, we talk about old school, how do you find the vertical dimension of rest? So since most people don't like it if you put Sharpie marks on their actual face that they have to get off, it can be nice to put a little piece of tape or a little Band-Aid or something like that at some point on their nose and their chin. It really is random, wherever you want, and then put a dot on it. Then you want them to sit up nice and straight, close their lips, swallow, and kind of say the letter mm. When you take your measurement, when you get a repeatable measurement, that's the vertical dimension of rest. So 3 millimeters less than that is their in the absence of any other information, is probably a good point for their vertical dimension of occlusion. So if they're over opened, part of your process is going to be to equilibrate something to get them to their correct VDO. Most of the time, they'll find that these patients are over closed, and we're going to want to be restoring some volume. So a leaf gauge like this is a great tool. So each one of these little leaves has a certain thickness, so you just keep adding up leaves until when the patient bites down on it, they get to that vertical dimension of occlusion that you've measured. So to take the bite, what you'll do is you'll get the right amount of leaves, you'll have them bite down gently, and usually the leaves will kind of work like a deprogrammer, but if not, you can ask them to try to bite on their back teeth or to try to touch the roof of their mouth with their tongue, and then hold that and then inject your bite material into the space between the arches with this in place. So that can be a nice way to get your CR bite. Now, one of the things you want to keep in mind, and we'll talk about this several times as we're going along, is that we're going to capture bite at the beginning, and then our goal is going to be to preserve that through the process. So a lot of times we'll be capturing our bite pre-treatment, and then what we'll be doing is aligning our preps and different things like that to that bite, so that way we can be very predictable. Incisal edge position. Like we talked about, the aesthetic position of the anterior teeth comes from the incisal edge position of number 8 and number 9, both anterior, posterior, and incisal-gingival. A lot of times with men, it looks nice to have 1 to 2 millimeters showing. Sometimes with ladies, as much as 3 to 4 millimeters can be good. Make sure that you understand what the patient would like. And again, we'll talk about this in a minute, but you want to, if at all possible, show them what you're planning to achieve for them. But knowing where this needs to be, we'll talk about this in a minute, all your tooth contour information will come from there. So you've done your initial assessment and you're ready to start capturing some data to do your treatment planning. So I've made up the term surface data for what you're trying to capture, because I would say that a CBCT scan or a PA or something that captures our subsurface data, but our surface data is either an intraoral scan or a physical impression that captures the external surface of the mouth. When we're using this procedure that we're talking about, we're going to be setting an initial bite, doing some mock-ups and things like that, and then constantly coming back to that bite, either digitally or analog. I like digital better, but either way. So these first records that you take need to be really good. Try to capture a lot of detail, avoid drags and stuff with your impression or voids. If you're doing an iOS scan, as large an area as you can, because it'll not only give you more options. Let's say you need to make up a treatment partial or something like that, or when you're aligning your files later to get a super great bite result, having more surface area makes the alignment easier in digital. One other thing about this is save these, because I'm sure you've all had this experience where you do a lot of treatment on a person and you get a great result and they come back and they say, well, my teeth were pretty good before. And it's kind of helpful to have something and say, oh, really? This is what I saw before. What do you think about that? Doesn't happen very often, but when it does, you'll be so happy you had that information. If you do physical models, one thing to keep in mind, especially if you do digital charting, I think most people do these days, your laboratory most of the time is going to be scanning those files anyhow, so you can ask them to give you the STL, so that way you don't have to have an office full of models. You can just save the digital files in your chart. So face bows. I feel like face bows are kind of one of those things that people either do it for everything or they don't like it and run the other way when the face bow comes out. So we probably don't always need to do a face bow on a comprehensive case like this. If we can get the correct centric relation bite in the mouth and your laboratory is trying to restore to that position, probably an average mounting will give you a good result. I will say, though, that if you're trying to open the bite on the articulator, using a face bow is going to make a big difference. One of the basic things about face bows is most of them, there's a few that work like this, but most of them are like this. And so you're going to be sending a big old contraption with all kinds of screws on it. I can't tell you as a technician how many cases I've gotten in the laboratory where the face bow, the screws were loosened so everything would fit in the box. And so you guys know once the screws are loosened, there's no point in doing this. So make sure that you're sure that when you talk to your team in the office that they understand that even if it's awkward to use, it needs to stay how it is. We can't loosen any of these screws. One other thing to keep in mind is dealing with cants. Cants, where the incisal angle is going the wrong direction, are one of those things that can be very simple to see in the mouth and extremely difficult to see in the laboratory, especially if the person has a facial asymmetry that's driving it. So a face bow can be a wonderful tool on that because when your technician is working on the case, he or she can look at the incisal angle and say, okay, well, if it's level to the bench, it's level in the mouth. So that can be another, if you're trying to correct a cant, I would consider using a face bow. And in the digital world, I like exocad. I use both. Exocad's virtual articulator has its own, it has a articulating plate like this, but you also can import a couple jaw motion files. So work with your laboratory on that if you're interested in doing the extreme digital workflow like that. That can be a great way to just add that much more accuracy to your case. How do you use a face bow, you might ask? So the first thing you want to keep in mind is that face bows are articulator specific. So make sure if you don't have one and you're getting one, that you get one that works with the articulator that you have. And you might want to talk to your laboratory. Many of the semi-adjustable and fully adjustable articulators have interchangeable magnetic bases. So that way you can just send the face bow and your laboratory can articulate it for you, and then you can use that face bow or the face bow mounted models on your own articulator. So do be thinking about that. So first, if you're going to use it, you want to attach your vertical shaft to the ear bow. So here's the ear bow, here's your vertical shaft, and make it nice and tight. And then you want to make a facial mark about 43 millimeters up from the incisal edge of 7 or 8 along Camper's plane here. So then you'll place your bite plate with this loose in the mouth, put a couple of cotton rolls on there, and have your patient hold it firmly against the maxillary teeth. Of course, as you know, the face bow is just to register the maxillary teeth, and then the mandibular teeth you'll register with your CR bite. So anyhow, while this is being held, you'll adjust your face bow so that you engage the external auditory meatai here, and then this crosses your 43 millimeter line. And then looking from the anterior, you want the ear bow to be level relative to the face. So once you have it all set up, then you'll go ahead and put your bite material on there. Again, have the patient bite down and hold it while you're with everything tightened, and that'll give you a registration. And again, then your laboratory will take that and it will make the relationship between the condyles of the articulator and the model the same as the relationship between the teeth and the person's jaw joint. So we can talk a little bit about tooth position, like I promised. So one of the interesting things about tooth position is that if you know this position and you know this position, and we talked about this is related to the relaxed lip position, this is related to how much gingival you want to show at your high smile, then you know what all the teeth should be. Because again, this golden, people say golden proportion is 62%. So most of the time, teeth that are truly made to golden proportion tend to look a little bit chubby. So a lot of times this is showing 80%, 72%. So you'll kind of want to decide, but whatever your proportion is, the width of this tooth will be that proportion to the length. The surface area of this tooth will be that proportion to the surface area of this tooth. And the mesial aspect of this tooth will be that proportion to the width of the lateral. Usually we line up the gingivals here, the incisal edges here. This is a 0.5 millimeter to sometimes a millimeter shorter. Perfect world if you can control everything. The other thing you'll want to keep in mind is what kind of smile curve do you want? Sometimes you'll see the smile line kind of curves like this following the lip, and sometimes it tends to be more straight. You might ask yourself, well, how do I know? Most of the time it has to do with the cusp tip of the premolar. Because depending, I mean, obviously if you can redo the whole, if you're doing both arches, you can do whatever you want. But if you're only doing one arch, it's helpful to have the teeth in occlusion. So sometimes you'll need to put the cusp tip in a certain place to get decent tooth morphology. And so if the cusp tip tends to be a little long, you're going to have more of a straight profile. And if it tends to be a little bit shorter, then you'll tend to have that little more curved profile. Because again, this is a fixed point. This is a fixed point. The way you kind of connect the dots determines the smile line. Few other little rules. In general, you want the centrals flat to the front. So in other words, you want them flat in terms of the tipping incisal to gingival, and you also want them flat mesial distally. Sometimes you'll turn them just a little bit to follow the facial curve, but in general, you want them flat. Of course, you want cross arch symmetry, gingival symmetry. I feel like the cuspid can be one of the most difficult teeth to contour. And so that's probably a good thing to talk to your patients about, because some patients are going to want kind of a more pointed look that seems perhaps more youthful. Some don't like that negative dark space around the tooth, and they're going to want a little bit flatter profile. Again, I feel like the flatter profile is in vogue these days, but make sure that you talk with your patient about that. I feel like that's one of the most difficult contouring decisions to make myself. We'll want to make sure that our line angles are very symmetric. For those of you that have done much with contouring, this is mostly a lab thing. Your one trick is this line and this line. If you move them together, it makes the crown look narrower. If you spread them apart, it makes it look wider. It's a good trick for dealing with teeth that are kind of crowded if we haven't dealt with them in any other way. You want to make sure you close your dark triangles from the gingival. And one of the rules, I always tell this to technicians, when you're looking at a restoration, it should, in terms of its trend, it should be slightly convex in this direction and slightly convex in this direction. If you look at a crown and you're like, man, that thing looks weird, I can't figure out what it is, look at it in profile and you might see that just the way the design software was used, there's a little flat spot right in this area. We want to make sure we get even centric occlusion and control our lateral interferences. And then make a decision about how we want to handle our function. Do we want cuspid rise, anterior guidance? What is the appropriate occlusal scheme for a given patient? Mock-up. So at this point, we have a bite. We know where our teeth ought to be. If at all possible, we definitely want to have a plan for where we're going. So this is old school. I'm sure you remember doing diagnostic wax-ups. This, I'd say, is new school. So using a 3D facial scan and then designing within the person's face. So depending on where you and your laboratory are at digitally, you'll probably fall somewhere in between here. But the main thing about this, it serves two purposes. One, it's a template. So we are going to do our darndest to get the final dental configuration to look just like this. So this is your plan. Like if you wonder, well, where am I headed? What do I need to do to get there? This is your plan. If there's a huge gingival mismatch here, then you got to do crown lengthening here, or it's going to look kind of dumb, or, at least talk about it. But the second part is this, which is really important. And that's that if at all possible, it would be nice to show your patient what you want to do. Now, obviously, this is a good case because we're missing a ton of facial volume. Sometimes you won't be able to do this, but we can make resin pretty thin and we can design it to draw over a lot of things. So if there's any way you can get a mock-up made and get it either bonded to place or at least seated to place so the patient can actually see where you're headed, that's super great. And then it gives you a chance to kind of look at what you're trying to do in the mouth. You'll notice if we're being picky, this midline is canted a little bit to the person's left. So we can say, oh, better straighten it out a little bit. The main thing you want to talk to your patients about this is shade. Most of the time we're going to be dealing with teeth that have some rotations, and so they won't be like this. There'll be some pretty thin spots, and so the shade will look a little bit blotchy. So we want to let the patients know that what I want you to look at is shape, not shade. Unless they're like, if you have one tooth that's way retruded, you can say, oh, look at that tooth. But they need to know ahead of time it's going to be a little bit blotchy. Again, if you're needing to shape an ovate ponic, you could kind of combine this with your ovate ponic efforts and make your mock-up part of your bridge. The sooner you show your patient the result, the sooner you get pictures and agreement and maybe even some scans or impressions of that, the better off everybody is, because you all have agreed, okay, this is what's going on in reality. This is where we're headed. All right. So you have approval and you're ready to do the case. What's next? So the first thing you want to do is deal with your structural issues, periodontal issues, like we talked about, endodontics, making your ovate ponics. I want to talk about ortho separately a little bit. Look at these beautiful ponics here. Not my case, but I'd be happy if it was. What a lovely case. That's what we can do. With perio, let's make sure that we understand how the patient got that way and that they're going to do something to not stay that way. And I mean, again, that's just a straightforward conversation. It's like you're making an investment. If you choose not to, if you bought a Lamborghini and you don't change the oil, it'll break just like any other car. So if you don't want to change the way that you're taking care of your teeth, maybe it doesn't make much sense for us to treat them, because you're going to wind up right back where you were at. Orthodontics. A lot of times we'll talk about, especially in large prosthetic cases, rapid ortho, which is basically prosthetic warpage of the tooth contour. I think it's funny sometimes that we'll do full court press for implants that have a long healing period, but we're like, oh, you don't want to do ortho? That's okay. With ortho being able to do it more rapidly and different things like that, I think it's good to push hard on that, because you can talk to your patient about the best way to get you a beautiful tooth is to have your tooth that we're going to shape in the exact right position. And especially if you're going to do some implants, because then while your implants are healing, you get your ortho done. So, but make sure that it's not like, oh, you don't want to do ortho. If you need it, push on it and have that same conversation with the patient. If you don't want to do this, that's okay, but I'm going to need to make these compromises with your case as a result. Are you all right with that? Implant placement. I like guided surgery. I've been in the guided surgery space for a long time, so I guess I should say that as a disclaimer right up front. But I do like something that I've heard relatively recently. A friend of mine said implant therapy is a prosthetic discipline with a surgical component. And I thought, how awesome. It's kind of the fancy way of saying people buy teeth, not implants. So there's a few things we want to look at when we're doing implants for these cases. And again, with these cases, we're going to be dealing with ones that are primarily tooth supported. So this would be replacing a missing tooth here or there. First thing is, in the aesthetic zone, the rules are changing a little bit, but I think most people still say don't do this because you tend to get a flat papilla in between. So if you have an option of doing implants under 6 and 7, or doing a big implant under 6 and an ovate ponic on 7, you'll probably get better gingival architecture with the ponic. Implant depth and implant diameter are very important because the right size implant at the right depth will give you just the perfect running room so that you can get that nice tulip-shaped emergence, just like a natural tooth, so that you don't have to do things that are either unesthetic or less than hygienic to close dark triangles. That's really important. And the last thing about these cases is that many times the reason a patient is doing this is because they're not very happy with where their teeth are. So we need the implant to be in an ideal position, but not just in an ideal position relative to where the teeth are, but it needs to be in an ideal position to where the teeth are going to be. And that's where guided can really help you, because then you can take your mock-up, scan it, align it to the plan, and then place the implant right under your mock-up, so you know you get a good result. Even if the implant alignment looks a little weird the way the person is now, you know, okay, I've made my mock-up, I know where I'm going, I'm getting my implant to support that. The other thing is, we'll talk about this in a minute, but with guided, it gives you some cool options for provisionalization as well. And here we are, provisionalization. So a lot of times, you guys know, we'll do a healing abutment and a flipper, and then the flipper, bam, 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 crushing our tissue. And most of the articles that I've seen talk about that the day you extract the tooth is the day you're going to have your very best gingival architecture. And so what you want to do is, instead of recreating it later, is you want to use something to hold that shape. So a custom temporary like this can be a great solution. And this is one of the cool things about guided. You know where the implant's going, you know where it's going to be clocked, so you can actually design a crown on a tie base and then deliver it right at the day of surgery. Now, these have to be way out of occlusion. They need to be a 0.5 millimeter out of occlusion in centric and any functional movement. But since 2014, several people I've talked to have said this is a settled issue. You can immediately provisionalize without compromising the health of the implant, you know, as long as you have primary stability, et cetera, et cetera. You can do hand-formed custom healing abutments, but they're a pain. Or you can do this, which is kind of a cool workflow. A lot of people don't know about this, but what you can do is you can do a 2-stage surgery, and on the day of surgery, place a healing, place a cover screw, well, place the implant, put a flow on it, scan the flow, and then place a cover screw and suture. When it's time to uncover, you can have a custom healing abutment made that looks just like this. You know, do the 2nd stage surgery, place the custom healing abutment, and then later on, you can order your final abutment, be it for a cement retained or a screw retained, because you can just punch a hole through the crown here and get this exact same emergence profile. So this is a really cool workflow that I feel like maybe not for every case, but for those cases where you need it, you get not an ugly looking plastic custom healing abutment, because I made a few that were they worked fine, but they sure weren't pretty, to something that's just beautiful and then can be easily replicated. So I like that workflow. Okay, enough said about that. So we're circling back to treatment sequencing, because we've kind of finished all the surgical interventions that require long healing processes. So again, we want to make sure that we start our ortho early and finish it early. And get those implants in as quickly as possible, along with any necessary grafting, our healing abutments, and any gingival recontouring we need to do. That's one thing to keep in mind if you're thinking about crown lengthening anyhow. You could do your crown lengthening while you're having your implants placed. Then we want to get the bite stable. And that may vary a little bit from one person to the next, but ultimately you want to have your patient in your definitive occlusion before you start prepping the case. It might be a night guard. If you can figure out a way to scan the bite with the patient wearing the night guard, it might be overlays, might be provisionalization. I would say that would be my least popular option, but you want to make sure that the person is experiencing the VDO and CR you want to do before you start on your treatment. So like we've talked about, if you add all these variables up, each case is going to be a little bit different, but you want to make sure you have a good plan for your sequencing. And again, you've talked with your patient about how the different processes are going to go. So you're done with all that and you're looking at the case. You want to make sure that you and your team have gotten the patient to a point that you can actually succeed at this. So this is kind of your, how did we do in the preparatory phase? I mean, obviously it's a pretty nice looking case, but you want to make sure your gingival positions look good, your tooth positions are good, your implant positions are good. And you'll look at it with your mock-up and you'll say, okay, I can definitely deliver this result with this. Or you might say, you know, this isn't quite where I need it, and talk with your specialty team and say, hey, can we get to where we need to be? And then worst case scenario, if there are biological or technical limitations to what we can achieve, you're going to have a conversation with your patient. And I would say rework the mock-ups so that way, again, before you start the big part of the treatment, you've come to an agreement about this is the result we're going to get. So I feel like most people do this step, but this is a step that can be overlooked sometimes. And if we don't put in a stop here, a lot of these things are difficult to go back and fix. So it's better to make sure, okay, I had a plan. I wanted to get the patient to this step before I started doing my preparations. I got there. I'm ready to go. Next step is provisionalization. Now, the provisionals are very important on these cases because this is the first time the patient's going to see exactly. I mean, we've done the mock-up, but the shades look weird, and sometimes the contours are a little bit compromised because of the natural teeth that are still there. This is the first time the patient's going to get to see what you can do. And these cases are hard to prep. You guys know if you've done them, it's going to be a pretty full day. So the last thing you want to do is like, okay, I'm done prepping. Now I got an hour of making temporaries. A, they don't come out very good. And B, you're just kind of fried. So it's better to come up with a plan to get yourself a nice temporary ahead of time. And I'd say these are really your three options. Chairside milling, what you'd want to do is scan your mock-up and then take scans mid-process so you can align your preps to your mock-up, and then use something like BioCopy to mill out your provisionals. If you have the ability to do that, I think that'd be a super slick workflow. I've never done it myself, but I mean, I don't see why you couldn't. The two that I've done are eggshells and a matrix. So what eggshells are is your laboratory will take the mock-up and they'll make the thinnest shell that they can out of either milled or printed PMMA, like this, and then send this to you. So the cool thing about this is that the external shape of the teeth looks great. The shape looks great. Essentially, you're doing the world's biggest reline on this, and then you have to finish the margins. If you've actually done one of these before, they're not as easy as they sound, because a lot of times you wind up reverse prepping the teeth to make them fit into the shell. So it's okay. Some people like it. again, I would try it on something easy like a 3-unit bridge or something like that before I did a huge case like this. You'll notice that these are splinted. You do tend to splint at least in segments, maybe posterior and anterior 3 segments, because locating one of these things is not very fun, believe you me. So that's one option. The other option is to make a matrix. So your laboratory will use your mock-up and either make a clear vacuform or a putty matrix over the outside of that. Usually you'll want it to extend onto the gingiva so that you have a solid index. And the good thing about that, especially if you use a clear matrix, is that you can see your preps through it. So you can make sure that you prepare enough if you're doing rapid ortho. In other words, if you're altering the tooth position restoratively. The putty tends to give you a finer surface texture and better detail in the proximals. The clear matrix is easier to see and work with, and you're less likely to get bubbles. So again, test it before you need it, but I would strongly recommend coming up with a provisionalization plan ahead of time. So then you're going to prep and impress. Now, one thing to keep in mind about these cases is that we're not trying to take a bite on the day of the preparation because we already have our bite. We took our bite, we mounted our case or digitally articulated our case, and then did our mock-up. So really what we're going to do is we're going to align our preps to the bite that we already have. So oftentimes with these kind of cases, it would be good to maybe prep like 5 through 12, leave the posterior teeth and scan that, then prep everything else and scan that. So that way you can align to the preoperative situation. Couple little tricks is it's best to align your preps labially and try to make sure that your prep is kind of in the center of the final restoration. That will help with the shade, especially if you're using a more translucent material. Figure out what you're going to do with dark restorations. I guess people don't really like basing them out anymore, but you may want to over prepare, and you'll definitely need to use a material that has nice block out. One of the main things we see in laboratories is when the preps are laid out at the incisal edge, it tends to create a highlight that doesn't look really nice. So when you're done preparing the anterior, just bevel the surface a little bit. It'll give you a much better aesthetic result. You'll find that your iOS is your best friend with these cases because you can take a nice scan. If you miss an area, no problem. Come back and add a little more data. If you take a full arch impression, it's mighty hard to get all those margins at the same time. And what if you got an implant in there? Good luck. How much better you can just put your scan body in there and scan right around it. So you can do it however you want, but I think you'll find that really your iOS is your best way of dealing with this. So a couple other things. If you're doing veneers, you'll probably want to use a matrix because I've never seen an eggshell work, and you'll want to spot bond the center of the prep before you form your provisionals on there. Oftentimes you'll want to splint them as well because they're just hard to keep in place. Once you get your provisionals done, you have a couple things you have to think about. First, the bite. Many times with these cases, we're correcting the bite. So you want to make sure that if the bite doesn't feel comfortable for the patient, is it because they're not used to your new bite, or is it really off? If you've had them open for a long time and they're a little sore, you may want to let them wear it for a day or two and just do a really rough equilibration and then tweak things in a couple days. Make sure you take photos of your provisionals. And then if you've had to do very little adjustment, I wouldn't necessarily take a scan or a model of it because you already have your mock-up and that's what you're trying to achieve. However, if you did have to make huge adjustments because of aesthetic issues or the like, you're going to have to take another set of scans or models, and then that will become your mock-up. So again, our goal is to have the mock-up, follow it all the way through. This is your chance to kind of do a double check and see if there's anything you need to change. So your lab will get all your records, and again, we'll align your preparations to the pre-op scan everything if it's physical or import it, and then start designing. One of the things that your laboratory is going to look at is kind of like this. Can we achieve, kind of like what you did before you prepped it, can we achieve what you want from the records that we have? It might be a good time for you to kind of work with your laboratory, have a look at the design, and make sure, yeah, that looks like exactly what we want. You can even show it to your patient. There's some cool viewer software you can use. The cool thing about this process is I get that it's a lot of work at the front end. But what's cool is that by the time you're ready to do the finals, you've already planned the case. You know what it needs to be. And same thing for your laboratory. It's like we have a template. So most of what we're doing is just making everything pretty. We're getting those nice line angles. We're getting our perfect proportions, nice anatomy, that sort of thing. I have a little theory that everything takes a certain amount of time. So doing a single crown takes a certain amount of time. Let's say it takes a total of, I don't know, 52 minutes in the office. So your only real choice is where do you spend the time? Do you spend 40 minutes at the beginning getting a perfect impression, bite, photos, all that stuff, and 12 minutes seating it? Or do you spend 10 minutes on your records and 42 minutes seating it? I'm kind of a fan of more time at the front end, make it easier at the back end. By the time we get to this stage, we want to know exactly what we're trying to achieve. We want to have everything set to achieve it. So it's really important. Obviously, the materials that you make your restorations from are important. Back in the olden days, the difference between what was strong and what was pretty, that's what my little continuum here is supposed to represent, was very, very different. We had gold crowns here and feldspathic veneers here. And these are strong and ugly, and these are pretty and extremely weak. So these days, the two ends of the spectrum have come together, which is really nice for us. We'll talk about that. But there are still some considerations. First, you want to look at both the biomechanical loads that your materials are going to be subjected to and what your patient wants. So if you see evidence of bruxism, you're going to want stronger materials. But they're oftentimes, the stronger materials usually aren't as translucent as the weaker materials. And if you have a patient that says, I want translucency, and back when you had that treatment conversation, that's what they really want, then you can say, great, I am looking forward to delivering that for you. I'm going to give you a night guard and you are going to wear it every day. And if you don't and your restorations break, then I'll be happy to charge you another fee to do it again. You know, again, you got to deliver what the patient wants, but then you also need to help them know what they need to do to be successful. The other thing I would say is that our template-based strategy is easier to implement with monolithics, because with a monolithic, I can design the exact shape that I want. If I'm going to do layering, micro layering, not as bad, but full layering, I got to use matrices and stuff. It's difficult to get it exactly the same. So if you can use monolithic, it makes it a little bit more predictable. Don't forget about your gold crowns. Obviously, most of your patients won't want to see it in the aesthetic zone, but if you have somebody who has severe bruxism and you're doing second molars, I feel like this is not a bad conversation to have. They're strong, they're biocompatible. The only things wrong with them is that they're expensive and they're not that pretty. So if we can mitigate the not prettiness, this is still a great option. I mean, how many of us know dentists who always do gold crowns on their own second molars? Zirconia, of course, has become kind of the go-to for everything. And one of the cool things is that aesthetics have moved to where you can do a nice aesthetic case with monolithic zirconia, which may have not been the case 5 or 6 years ago. The main differentiator in zirconia is how much yttria is in it, because that affects the crystal phase and basically how translucent it is. This little slide goes through kind of the different ways that zirconias are classed. So the 3 Ys are the original ones that were really strong and maybe not as pretty. And then you got 4 Ys, 5 Ys, 6 Ys. These are newer. These are going to be a little more translucent. And so these are stronger and these are prettier. And then there's kind of two ways that people are dealing with making the zirconia prettier. One is by having layers of the same mole of yttria, but using different shades essentially, or even blue modifiers to kind of create an appearance of translucent. Of course, this one would be translucent. Or this has kind of become more popular, is where you have different layers of different strengths. So you finish up with a 5Y on the incisal, so you got some nice translucence, and then you're using a 3Y down by the margin to give you some really good strength. So the reason that zirconia works so well, I'm sure a lot of you know this, is something called transformation toughening. Everything has microscopic flaws in it. In a ceramic like zirconia, they're called microcracks. And when you apply force to it, if a crack is going to propagate, it's going to start at a microcrack. So here's the interesting thing about zirconia. You got two crystals on either side of a crack. When you apply force, zirconia goes through a phase shift, and it shifts from tetragonal to monoclinic. And so what happens is it grows a little bit. So it has the effect of pushing back on those stresses. That's why the zirconia is so much stronger. However, that effect seems to be a little bit less with the higher Y materials, which is probably why they're not quite as strong. So you want to make sure that you work with your laboratory to pick a material that'll work well for your case, both aesthetically and biomechanically. One of the limitations that we ran into not that long ago was that you couldn't bond zirconia, but with the advent of MDP primers like these, you can. Zirconia bonding is very predictable now. So if you have to do, we want to get our materials in the aesthetic zone. We want to use the same material as much as possible. So if we're doing a zirconia 3-unit bridge next to a veneer, probably your best result is going to be to use the same zirconia for both. If you have to do dissimilar materials, you really have to think about that, because even if they look awesome on the bench, what I've found is that because of variances in translucency and the like, when you go to seed it, they don't look quite as awesome. Layered zirconia can be a good solution if you need to do lithium disilicate for a veneer or something like that. Back in the day, there were some people that were concerned about delamination on these, but that really isn't a thing anymore. I think it was just technicians getting used to a new class of ceramics, because we'd always put porcelain on PFMs, and I think some people were putting PFM porcelain on zirconia, which isn't the best. One thing to keep in mind is that metals, the coefficient of thermal expansion varies widely, and finding porcelains that work with it is a pain. Zirconia is always exactly the same, so it's really an optimal substrate for applying porcelain. These are more expensive, they're not as popular, but definitely keep them in your toolbox, especially in the maxillary anterior. You can do the equivalent of a metal lingual. You can have solid zirconia on the lingual and some layering on the facial to get a really, really nice result. Using zirconia. This is kind of the same advice I'm going to say with your specialists. So start trying all your laboratories' zirconia options now on cases where the aesthetics are not as critical, so that you know with your lab and in your hands, you get this result with this zirconia. So that way, when you're trying to treatment plan these cases and pick what you want, you're like, well, I know. I like the 4Y, and I like a little bit of 5Y in my incisors. You know, whatever that you've worked together and you know exactly what you want. Work with your laboratory, but try it ahead of time. Very, very important. Last but not least, I want to talk about lithium silicate or lithium disilicate. These are a beautiful restoration, very easy to bond, and they can be micro-layered. One of the cool things with these is there are so many different options for ingots. So you can pick a more translucent or a less translucent, depending on how much shade control. Keep in mind that the higher translucent ingots also tend to have a lower value So you kind of need to, just because it says a HTBL3 doesn't necessarily mean when you make the restoration, it'll actually look like a BL3. It might look like a D1. I know D1 isn't a real shade, but I'm saying if there was. So be cautious with the translucence and just make sure that you can compensate for it in other ways. You can control some discoloration with this, but extreme discoloration, I'd probably recommend doing a zirconia. And again, if you're going to be using this material, one central, probably not the best way to do it. You want to make sure that you're using this all the way through the aesthetic zone to get the best result.